Welcome to the new lecture that I'm going to talk today, is surgical jaundice. I'm going to start with a new style that we will ask few questions and the answer itself will give all the solution to this. But in between, I'll put some questions to the students as a quiz and subsequently we'll discuss that questions. So the questions which we are going to ask are, what is jaundice and its types? Is it obstructive? Where is the obstruction? What is the patient fit for the procedure? What is the cause of obstruction? Is it curable or not curable, palliative? How shall we prepare pre-operatively? And then we'll start the management. So let us discuss what is jaundice and its types. Jaundice is defined as a yellow discoloration of skin, eye, other mucous membranes, body fluid due to raised serum bilirubin. It means it has got 2 points. One is clinical, that should be yellow discoloration of the body, and biochemical, where the serum bilirubin has to be elevated. So question number 1, which body fluid is not yellow in obstructive jaundice? So before going further, let us see how the bilirubin is formed from the old rigid RBC. When they goes into through the reticuloendothelial system, the hemoglobin comes out of the cell. This hemoglobin has got 2 components, heme and globin. The globin goes to the protein pool. Heme again take out the iron to the iron pool, and this heme without iron is the tetrapylate ring, and that is what is known as the unconjugated bilirubin. It is fat soluble. Then this bilirubin goes to the liver for conjugation with the help of glucuronide transferase into monoglucuronides and diglucuronides, and then it gets absorbed, it was secreted into the bile and enters the intestine, where around 10% get absorbed and recirculates to the urine and comes out in the urine to give a color in the urine as urobilinogen, and then further divides to urobilin, and majority comes from the fecal matter is turcobilin. The bile flow from the liver to the small intestine is physiological. The obstruction may be at various levels. Obstruction at or below the confluence cause surgical jaundice. This, please mention this. Surgical obstructive jaundice, age is no problem and no issue because it can be seen in any age group. So we'll have to diagnose based on the features. You can see a child with a bluish hue on the eye because of prolonged jaundice, and a elderly person, you can see clearly the sclera is looking yellow, and there's no doubt that this is non-jaundice. Still, then comes how to differentiate what are the types of jaundice and how to distinguish between these 3. One is pre-hepatic, other known as hemolytic jaundice. Here the bilirubin level will be unconjugated bilirubin. The AST/ALT will be normal. The SAP is likely to be normal, but mild elevation may be there because of the bony alkaline phosphatase. Hepatic jaundice, it is a mixed conjugated unconjugated bilirubin. The gross elevation of AST and ALT because hepatitis, that is loss of hepatocytes, and the alkaline phosphate is normal. Whereas the topic which we are discussing today is the post-hepatic or obstructive jaundice. It's more of conjugated bilirubin, AST/ALT will be near normal, and gross elevation of serum alkaline phosphatase. Question number 2. A liver looks like this. What is the diagnosis? Name the condition in which this color liver is seen. So now that we have defined jaundice, which are 2 connotations, one is clinical, second is biochemical serum bilirubin level. Is it obstructive? I will ask one more question to you people, that is the biliary obstruction and obstructive jaundice are same or different? I'll give a small example. Here you see the CT scan where the ISBR, biliary radicals are dilated on the left lobe liver only. Will the patient have jaundice? No. Because right lobe is working very well. It is draining the bile, so patient will not have jaundice, but it shows biliary obstruction. So biliary obstruction and surgical obstructive jaundice are not equal. So how to proceed if you see a patient of surgical obstructive jaundice? As routine, we take a history, you examine, do a LFT and ultrasound. I have decided this level of investigation into 3-4 levels. That is written on the right hand side. LFT and abdominal ultrasound is level 1 investigation. MRI, MR cholangiogram level 2 investigation. that endoscopy procedures like, for example, side-wing endoscopy, endoscopic ultrasound, and intraductal ultrasound in level 3 investigation. A tissue diagnosis through this will be level 4 investigation. And when the staging of the disease with imaging and tumor markers, this will be stage 5. And before a definitive curative surgery, better to do a diagnostic laparoscopy. That is the level 6 investigation we should do. History. What all important things that will be taken in the history are itching. This patient will have itching all over the body. The stool color will be pale colored stool, and you must ask for fever for the evidence of cholangitis. Number 2, examination of the gallbladder, is it palpable or not palpable. Similarly, liver, spleen, and free fluid. We'll discuss one by one, and then do a liver function test and trans-abdominal ultrasound. See, this is the type of itching. Itching is so intense that they keep on itching 24/7. Even they take the help of their relatives to keep itching on the backside. This fellow had a very not gross rise of bilirubin, but it's the duration of obstruction that decides the intensity of itching. This is what is pale colored stool. Many people they give example, say something, but seeing is believing. This is white colored stool and typical of obstructive jaundice. Now, if your gallbladder is palpable, you must remember the Courvoisier's law. I make it very simple for you that it has got a precondition that is applicable only jaundice patient. It is a condition where gallbladder is palpable in a both jaundice case patient, then it has got a positive inference. What is the positive inference? The cause is because of carcinoma head of pancreas. What is the negative inference? Not because of the CBD stone. There may be exception, both positive side exception and negative side exceptions. Liver. What is the value of the liver in jaundice? If the liver is enlarged, liver is normal liver, it's a very good sign. That patient will recover fully. If the liver is not enlarging, it is a bad sign because liver function is bad. It is very firm, so it is not enlarging. If there is splenomegaly, that indicates it's a portal hypertension because the raised intrabiliary pressure is obstructing the portal vein, which is a low pressure flow. Ascites, please do not operate. If patient is ascites, is a bad sign. Only palliative procedure can be done. So in liver function test, in obstructive jaundice, the bilirubin goes around 20 mg/% because it is water soluble. Most of them will come out in the urine because water is produced, and mostly conjugated bilirubin. AST/ALT I have already told you normal. ALP is grossly elevated, and look for albumin in this duration of jaundice, because if the duration of jaundice is more than 21 days, that's half-life, the albumin level will be low. If it is albumin normal, it is short duration of surgical jaundice. In the other investigation, you must do everything routine, hemogram, urea, creatinine, sugar, everything, because you are going to operate. And this is your level 1 investigation, besides the ultrasound and the LFT. Level 2, MRCP and CT scan. And then, so let's investigation. Why do we investigate further? To find out the location of obstruction, cause of obstruction, and how the patient is fit for a procedure. Level 1 we have already discussed, so there's no point to think, but I want to give a stress. The prothrombin time and other tests needs to be done, because when the bile is not entering into the bowel, the vitamin K absorption will not take place. That is why prothrombin time and correction of that is necessary. So ultrasound we have already told, because it will show that the basic principle of obstructive jaundice in imaging finding will be the proximal part of the bile duct will dilate till the obstruction, and the junction of the dilatation and non-dilated part of the location is the site of the obstruction. So what you infer here, end of dilation is equal to site of obstruction. So it should be very clear in obstructive jaundice and imaging. So the transabdominal ultrasound is very easily available, so that is why it is done most commonly, and it will detect the ISBR dilatation and also detect some stone in the gallbladder, but incidence of detecting CBD stone is hardly 20%. So don't believe on abdominal ultrasound or CBD stone, you will do some other imaging. You can see the ISBR is dilated, and in the both it should be on the both lobe of the liver. And here, how do you know there are this is dilated? Because there are three tubular structures that traverses all over the liver. One is hepatic artery, second is the portal vein, third is the bile duct. The largest among these is portal venous radicle. And if the bile duct dilation is at least 50% that of the portal vein radicle, it is considered as dilated. Similarly, you can see the CBD, and there are three structures that go enter to posterior. One is the CBD, second is portal vein, third is the IVC. So here you can make it out, but seeing the stones is very unusual. You can see a stone and see the shadowing. The shadowing means if you stand on the sun, you can see the shadow. If in morning it goes posteriorly towards the west, and similarly shadow will be from the probe towards the posterior part. This is shadowing of both these things showing this stone with shadowing. Occasionally, you might find a tubular structures in the CBD, and that is because a tubular structure may be worm. What is that worm? Mostly roundworm. And roundworm, as soon as they take breathing from the bowel lumen gas, but once they enters the CBD, it is no air in that, and they usually die, disintegrate, cause problem, jaundice, and fever. And this is the roundworm. Both are there. You can see two example. They are in the lumen, but they are alive. There's a question coming up: who is the culprit? Male worm, female worm, or both the worms? I will discuss in the last of the talk. So what I have learned so far is the hallmark of surgical obstructive jaundice are: one, raised conjugated bilirubin, raised serum alkaline phosphatase and 5-nucleotidase, dilated biliary tree. Both is better, maybe unilateral, maybe bilateral, usually bilateral, unless there's a disease there. Is this true in all the time? Usually, but there may be some exception that we'll discuss if time permits. Then comes, where is the obstruction? We have already dealt with, it is jaundice and its types, and is it obstructive? After answering the third question will be, where is the obstruction? Let us see the diagram. I have demonstrated few stones in the left lobe duct. Right duct is open, and there is obstruction at the confluence that I have already stressed it to you. Anywhere the obstruction is at or below the confluence will give rise to surgical obstructive jaundice. If there is intrahepatic, there is biliary obstruction, that will indicated in the form of the raised alkaline phosphatase, or bilirubin will be normal. The next is benign stricture. Benign stricture means it is commonest cause is post-cholecystectomy injury to the common duct, and this is the stones may be in the CBD or maybe cancer. If there is stone in this point at the lower end of the hepatic duct, pancreatic duct will be normal. If it is there after the joining with the bile duct and common channel, they both will be dilated. I'll give you one by one example. So again, I would like to stress you, the end of dilation is the site of obstruction. So what is before going to the imaging, let us see what are the obstructive causes. One is congenital, where you see in the childhood, extrahepatic biliary obstruction is seen. I have shown you a picture of the child initially, that is extrahepatic biliary atresia. A choledochal cyst, at times it causes jaundice, and there you can see very clearly. Benign, and there are only two, stones and benign strictures. In the malignant, from the ampulla and upward is a periampullary carcinoma. Tumor, where there is tripercussion tumor with the confluence of the right and right duct to the cystic duct, and SCC or some other tumor mass in the hilum obstructing the common bile duct. There's a question coming up: what are the components of periampullary carcinoma? It is a periampullary because many may be joined up together. So we have already said that we have done routine LFT, MRCP. Let us go to the now MRCP. MRCP is a very good investigation, no radiation, and it's from any age group you do, but age group, children, they require some sedation or can be done with general anesthesia, and it is very good for CBD stones and any bile duct which is dilated or undilated. You can see one MRCP picture, what is showing the whole biliary tree, including gallbladder, is dilated. In the lower part of the bile duct, one more duct which is going parallel to this, and this is the pancreatic duct, main pancreatic duct. Because there are two signs, two ducts are dilated, this is done a double duct sign. This is typical that the obstruction is at the ampulla after the both joining of both the ducts. In this scenario, the diagnosis is periampullary carcinoma. You can see another MRCP picture where the main pancreatic duct is grossly dilated. There is another cystic lesion in the head of pancreas, and thereby that area, the duct is common bile duct is not dilated. So this is carcinoma head of pancreas lesion. Here you can see the bile duct is dilated, pancreatic duct is normal. So it is a bile duct lesion. So what is the other advantage of MRCP? You can do a virtual colonoscopy. Means you can see the inside of the lumen. It's useful in stone and malignancy. And here nothing special is necessary. A software is available where you can do this job. But a contrast may be necessary. Here this is a 3D, you can take a 3D picture as well. Here they have done a virtual imaging, and what is done is the cystic duct is joining just below the ampulla, and the duct is going, cystic duct is going posterior to the common bile duct. Usually it joins at the right side of the common bile duct. If you try dissecting more and more of cystic duct, here you are likely to injure the common bile duct. So what information we have got so far? This is jaundice. Is it obstructive? And where is the obstruction? We will discuss a little more on the other investigation. What is the cause of obstruction? Is it benign or malignant? So to look for this, we'll go one step ahead, then we'll go to endoscopy, little more of invasive. Here there are three procedures that can be done in same sitting: a side wing endoscopy, endoscopic ultrasound, transduodenal, intraductal ultrasound, and tissue diagnosis for breast cytology or a ultrasound guided needle aspiration. So before side wing endoscopy, before the ultrasound, you can just do a look at the side wing endoscopy. You can see there's a clear-cut growth in the ampulla. So here what is necessary is just take a biopsy, no other test is necessary. You can see at times the bile duct is open. In some situations, this is a post-operative case. And if you do endoscopy through the duodenum, what you see is all around the duodenum, that is duodenal wall, bile duct, head of pancreas, everything you can see, and any lymph nodes close to it, it is actually coming out to be shown very good. It's better than CT, localized ultrasound in this, but interpretation of the individual is more important. Here you can see a needle is going, this is the needle, and this is the mass, hypoechoic lesion, and you can take a biopsy from this cytology. After that, everything is done. You can do a ERCP. This actually the biopsy can be done before, after the ERCP, where you can do the ERCP. This cannula has gone, ampulla looks quite bulky. And here what you see is that bile duct is cut off at the level. This is a post-operative cholecystectomy bile duct injury. This another case of ERCP, which what is showing is there's a common channel. The pancreatic duct is visible, bile duct is dilated proximally because of the force of the pressure of the contrast injected. There is a radio-opaque gallstone, and there's narrowing in the junction of common hepatic right hepatic duct, left hepatic duct. This is typical location of carcinoma of gallbladder infiltration. Another case, it is a cholangiocarcinoma, but the long narrowing is a point against it. So then you come to intraductal ultrasound. Intraductal ultrasound, what is this? A small transducer that can be taken through the biopsy channel to the bile duct as a ERCP procedure. There you can see, and this is very good, highly sensitive in Merij's syndrome, almost 100% specificity. It is post ERCP confirmation of stone clearance. This is also a very good test, and this is not available in most of the places, available in higher centers only. This is one of the image of the intraductal ultrasound. You can see the lymph nodes showing as just periductal lymph nodes, and here you can see that there is a grossly dilated duct. This is the transducer. You can see the lymph nodes surrounding. That means it may be infective or maybe malignancy. So we'll have to corroborate with other tests. And the cytology, if the cells are malignant, it's a good pathologist can tell you this is malignant lesion or benign lesion. Next comes, so we have diagnosed that it is a jaundice, it is obstructive jaundice. We have located the obstruction site. Then for staging, we have a tissue diagnosis. Staging means T and M, tumor, node, and metastasis. By this MDCT, PET-CT, fusion images or 3D pictures, then you can make a final diagnosis. How to manage now? I have told you that one more test needs to be done before you are going to do surgery. There's a diagnostic laparoscopy, which CT scan may be missed, is subcentimetric metastasis or peritoneal nodules. How to manage? You have to prepare the patient because the patient is fasting, is not taking enough water. So number one is hydration, because this urine is taking out all the conjugated bilirubin. At times the hydration is not adequate. They block the thing and the urine output falls. It is post-operative fall in urine output, a very dangerous affair. And you need to give IV fluid, more of glucose, so that urine output will become all right. Never operate a case with a low urine output. Urine output must be 1.5 liters minimum a day for 3 consecutive days. Then only patient will be fit for surgery. If you would operate with low urine output, they are likely to go into hepatorenal syndrome. Correct the coagulation defect by vitamin K. There's a question coming up. I'll tell you what is the daily requirement of vitamin K. You can note it down. And you'll have to continue giving because it is not getting absorbed. Improve the nutrition because patient is fasting, I told you. Maintain the bowel integrity by giving bile acids. There are 2 medicines available, UDCA and CDCA, also deoxycholic acid and deoxycholic acid. This is available in tablets. Give these tablets for a week before at least. The fecal load has to be reduced by giving some laxative like lactulose, which has no side effects, and arrange adequate blood and fresh frozen plasma so that any bleeding during surgery can be taken care of. So this question I've already told you, what is the daily need of vitamin K and what are the sources of vitamin K in your diet? The aim of management now is remove the obstruction and re-establish the flow of bile into the upper jejunum, upper small bowel. So let us come to the specific management now. The specific management: choledochal cyst, CVD stone, benign stricture, and malignant lesion. We'll go one by one. It's a choledochal cyst type 1. And you can see it's not a rare condition. You will see in quite a bit. This is a young girl holding the cyst since childhood. As you can see, the lump very clearly is a huge choledochal cyst. That's why jaundice, obstructive jaundice. You can see the cyst which is excised, and we have done a hepaticojejunostomy just at the confluence. CVD stones. If there is CVD stone detected, the ERCP endotherapy, that means you put a ERCP, cut the sphincter and remove the catheter by a balloon sweep or by basketing, and at least 2 attempts must be given to such patients because this has got a very minimal morbidity. Next option will be laparoscopy or a robotic surgery where you can do cystic, transcystic. Then the other option will be transcystic removal from the CVD. And last option is open choledocholichotomy. This is a CVD stone. You can do the MRCP, the moon sign in the lower end. This is, you can see the ERCP procedure on the way because multiple filling defects. This is another ERCP going on with multiple filling defects where we can remove the stones. This is I have done a transcystic removal of the stone. Here you must be sure that how many stones are there, or else you must have a choledocoscope, because you can see a stone here, then you have confirmed that every stone is removed. With a choledocoscope, actually we have used a cystoscope with a ureteroscope, which can go through the cystic duct. And this is you can see the laparoscopic view of this so that you can do laparoscopic. This is another, this is a video actually, but the video is not working. I'll see sometime else. So the benign stricture, I've already told that it's a cause is post-cholecystectomy CVD injury. You can see one of the case where it was done for the second hepaticojejunostomy while duct is not dilated. But even if whenever you go in, I could not thought why it is not dilated. That's I did a cholangiogram. But if you do surgery, you must do a long anastomosis, almost 3 centimeter. You can see from the fissure, I cut the left duct totally to make a longer anastomosis. You can see the happy lady subsequently. In the malignant obstruction, if it is localized, then do a radical surgery. If it is advanced, chance of survival is more than 6 months, do a palliative procedures. It is less than 6 months, do a stenting. Endoscopic cover metal stent is the ideal for palliative surgery whose survival less than 6 months. Where it cannot be done through the ERCP, best option is do a PT-BD, percutaneous transhepatic biliary drainage, and then push it through the tumor into the duodenum, because you don't want to keep it outside hanging tube and collecting bile. That reduces the quality of life and more painful life. In a localized disease, I've told you before doing the surgery, do a diagnostic laparoscopy and be sure that there's no advanced disease or metastatic disease. Here we are doing a Whipple, so you can see the portal vein, and the portal vein, the neck of the pancreas dissected is lifted off. Now another case, the pancreas is transected. This is the portal vein, one hepatic artery arising for supramesenteric, which is coming from the right of the portal vein. This is a very dangerous scenario. Unless we note it, you will injure, then there will be hepatic necrosis will take place. Another case, portal vein is all dissected out, pancreatic duct is open. This is the splenic vein site where the splenic is joining. This is the middle colic vein which is joining there. In this place, it has to be preserved for venous drainage of the transverse colon. This is the specimen. Here you can see the gallbladder, you see everything. I'm going to ask a question to you. Name the anatomical structures removed during Whipple procedure. And at the end of the surgery, you must see, cut open the specimen, see the periampullary carcinoma here, and you can see the bile duct through the bile duct, the instruments coming out, so causing the bile duct obstruction. And this is the post-op, this is the incision given, which is closed. The question is, what are these structures removed? Same question I have told you. Now let us come back to question number 1. I'll give you the answer for all the queries. Question number 1 is, which body fluid are not yellow? It is bile. Diyatale andhera. Because all fluids will be yellow except the bile. When you are operating, if you find watery fluid, it is the point. Which color in this is, which is the condition of the liver, where its color is like this? In congenital hyperbilirubinemia, there are 3 conditions. The conditions are Gilbert's syndrome, Dubin-Johnson syndrome, and Rotor. Dubin-Johnson accumulates the pigment, then the blue color to the liver, and this is the same. I had one opportunity to do this laparoscopic cholecystectomy in this case. Question number 3. What are the components of periampullary carcinoma? They are ampulla, duodenal mucosa, Brunner's gland, bile duct, pancreatic duct, and the pancreatic tissue adjoining the bile duct and the pancreatic duct. Amongst this, bile duct cancer has got a very good prognosis. Question number 4. What is the daily need of vitamin K? There is no requirement of vitamin K, because vitamin K is synthesized by our bacteria in the colon. Only bile is required for vitamin K absorption because it is fat-soluble vitamins. The common source, when everything is available inside, no food can give you adequate vitamin K. So obviously, you can green leafy vegetables and other products can give you, but majority of them are very little scanty. The items which are removed during Whipple's procedure are gastric antrum, the pylorus, along with the pylorus, whole of duodenum, head of pancreas, common bile duct, cystic duct, gallbladder, proximal jejunum, adjoining fatty tissue and lymph nodes. These are the structures en masse you remove and do all this continuity of the anastomosis. This question is, I thought this next question, the causes of jaundice is various color of the liver. This is, one is alcoholic cirrhosis. This is NAS, non-alcoholic hepatic steatosis. And this is hepatitis B when the liver is this color. And this is primary biliary cirrhosis, only one case which I have operated, very rare in India. Thank you very much. Hope you enjoyed my talk. Thank you very much. See you sometime.